Welcome to the Resilient Performance Podcast. I'm your host, Doug Kachijian, and today I'm joined by Dr. John Childs. Dr. Childs is a founder and CEO of Evidence in Motion and partner in Confluent Health, which includes EIM, a network of 70-plus physical therapy clinics in Indiana, Kentucky, North Carolina, Oklahoma, and Texas, and Fit for Work, which provides employers consultative services to decrease injuries and workmen's compensation costs. A graduate from the US Air Force Academy with a BS in biology, he completed his master's in physical therapy from US Army-Baylor University, MBA from the University of Arizona, Master of Science in Musculoskeletal Physical Therapy from the University of Pittsburgh, his PhD in Rehabilitation Science, also from the University of Pittsburgh, and a DPT or Doctoral Physical Therapy from the Evidence in Motion Institute of Health Professions. Dr. Childs is a board-certified Orthopaedic Clinical Specialist from the American Board of Physical Therapy Specialties and a fellow in the American Academy of Orthopedic and Manual Physical Therapists. A professor in the Doctoral Physical Therapy Program at South College and associate professor in the US Army-Baylor Doctoral Program in Physical Therapy, Dr. Childs served a 20-year career in the Air Force, having collaborated on more than $10 million in grant funding and published more than 150 papers in leading scientific journals. He currently serves as an associate editor for both the Physical Therapy and Journal of Orthopedic and Sports Physical Therapy journals. Dr. Childs was recently recognized as a healthcare hero in San Antonio and is the youngest ever fellow of the American Physical Therapy Association, the profession's highest honor recognizing individuals for professional excellence and making a profound impact in advancing the profession. Dr. Childs is an innovator in medical education whose ideas can be extrapolated into other realms of learning. He's somebody that I've personally entrusted in the past to help audit my own medical practice from both a clinical and a business standpoint. I think you'll enjoy his perspective on how to streamline education in a way that won't compromise quality. John, thanks so much for taking the time to join us. I wanted to start out, we're going to get into the particulars in a little bit. So you have developed kind of a unique medical educational model. And before we get into those specifics, obviously you wouldn't feel compelled to create that kind of a model unless you saw some shortcomings with traditional physical therapy education and perhaps more broadly medical and general education. So what were those things that you identified, again, that compelled you to create your unique model?
Doug, well, first of all, thanks for the opportunity to join you on the podcast. You know, my background is really as much or more in academics as anything. I did my PhD at the University of Pittsburgh back in the early 2000s, and then spent the latter half of my military career on faculty in the US Army-Baylor PT program. So spent a lot of time in so-called traditional entry-level education, and really got exposed to the 250 plus, PT programs out there that are largely conducting physical therapy education in kind of a brick and mortar model, cohort sizes of, 30 to 40 students per class, 8 to 9 faculty to support those students. And so over that period of time, we've seen, this huge, increase in demand for physical therapists. PT shows up on every Bureau of Labor and Statistics, profile as being, top 10 profession. So lots of growth. And so because of that, the educational community is trying to keep up with the demand. So every university and their brother are trying to start, PT schools, and in order to cope with this demand, but they're doing it very much in a traditional brick and mortar model, 30 to 40 students, 8, 9 faculty. And so what we're seeing is are a number of things. Huge dilution in the faculty pool. There's probably 300 open faculty positions, 40 to 50 open program director positions because of all these new schools that are starting in sort of traditional brick and mortar ways. And of course, during that same period of time, we've seen increases in tuition, continue to rise, not just within PT school, but higher education in general. Add on top of that, the whole transition of our profession from the master's to the DPT, which in large part took place in the early to mid 2000s. And so what happened was PT school used to be about 18 months or so in length, maybe 2 years in the master's environment. And then when we went to the DPT, all of a sudden it became 3 years. And when you look back at, well, how did we get from 18 months to 3 years? The answer to that is not a very logical answer, at least based on the needs of the curriculum. So when we shifted to the DPT, we added things like pharmacology, radiology, imaging, medical screening, the kinds of content that were necessary to justify a doctoring profession. But when you look at that content, you can probably get that content done in a 3, 4, at most 6-month period of time. And yet higher education, all of a sudden we end up with a full year of extra education in the DPT curriculum. And so that was driven in large part, frankly, by the supply and demand. I mean, higher education had an opportunity to add on probably a little more length than was really necessary, but the market justified it and would be willing to pay for it. And, I always say if applicants would pay for a 5-year or a 10-year DPT, I can assure you higher education would be more than willing to accommodate, right? So it has a lot to do with the willingness of the applicant pool to pay. And because there's been such a high demand, that market has been very robust, and the 3-year DPT has sort of worked. But we see these big student debt issues now, and as a parent advising my own kids, I have to honestly say, gosh, going into physical therapy in the typical kind of model probably doesn't make a whole lot of sense from an ROI perspective. And so we just got interested in really trying to disrupt that traditional model and try to be a part of the solution in perhaps reducing the length of PT school and adding more value into the system so that we don't lose our best applicants to other professions.
Understood. So you're essentially proposing to do the same job or possibly even a better job in less time. So can you get a little bit more into the specifics of what you propose as an alternative to the status quo and then, the rationale for it? And then potentially, are you familiar with any data or empirical data that's helped to drive the way that you've shaped your program?
Yeah, so a little bit of background is probably helpful. On the EIM side, we've been building blended model certification programs, residency programs, and fellowship programs over the last probably 10 years or so, working with a lot of large employers around the country who use our programs as a means to recruit and retain therapists. So most of the students in our programs are working full-time in physical therapy. They're completing our content online through both synchronous and asynchronous tools and technology, and then they come together on site for the hands-on courses. And so over the last number of years, we've gotten some level of expertise, if you will, in how to do that. And we just felt like the timing and environment was right to take what we've learned in the post-professional delivery and then move that, if you will, kind of upstream into entry-level education. And so the real kind of differentiators, I suppose, in terms of the model that we've built is that, number one, it's a 2-year model instead of 3 years, which that's, a big difference. It helps save students about a third of tuition costs. Plus, the students in the third year, they're actually earning an income as opposed to paying tuition. So if you look at the sort of the overall cost of PT education in a 2-year model versus a 3-year model, it's roughly half of what it would cost to go to school elsewhere because of that third-year income that you're making. So it's a 2-year program rather than 3. The other sort of distinctive, I suppose, is that our students don't necessarily have to live in the local area of the campus. So we're able to recruit students from all over the country. They complete the didactic content of the curriculum online, and I hesitate again to use the word online because it conjures up these ideas of students passively sitting in front of their computer watching videos. Our students are participating in live virtual classrooms 3 to 4 hours a day, 3 to 4 days a week, with lots of engagement from faculty who are teaching into those live sessions. And the difference is the students have done the readings, they've watched all the videos and recordings and those kinds of things in advance, so that when they come to the classroom, the faculty are engaging with the students in clinical reasoning and sort of higher order sort of learning activities, if you will, as opposed to simply lecturing to the students. So they've already watched in those lectures in advance of the class. And then for the hands-on portion, they come to the campus for 10 to 12 days at a time for what we call lab immersion models, where the students from 8 in the morning until 5 in the evening are in lab all day long. So it's not interrupted by lecture, lab. It's an all-day lab session. And it's quite an intense session, as you might imagine. They're on their feet all day long, just like they are in the clinic, so that when they get out to the clinic, we feel like our students have a real fitness, if you will, for the clinical setting, because they've already been trained in a lab model that looks and feels a lot like the clinic.
That's cool. And like you said, there's kind of a stigma with online learning, but the world is obviously changing. And at one time there was a stigma even with online dating, and now people meet their spouses online and no one thinks anything of it. So that's definitely the direction I think that education's going in to some degree. Now, maybe if you could provide a specific example of, how you would incorporate the online model and get a sort of a tangible learning effect. So like with anatomy, that's one of the kind of rite of passages of any entry-level medical program, whether it's physician programs, physical therapy, nursing. And, people take great pride in doing these cadaver anatomy courses where they smell like formaldehyde when they get out, and they spend, 2.5 hours out of the allotted 3 hours in lab trying to actually get through all of the sort of non-essential stuff so they can identify the structures that they want to actually learn about. So what's, in your opinion, the anatomy thing, is there validity to the cadaver model, or can you even create, get the same endpoint by doing it online or with a different type of model than the cadaver?
No, that's a great question, and I guess I would sort of preface my response for saying this whole issue of cadaver versus non-cadaver models certainly preceded the blended online model, right? So we have a number of traditional schools out there now who don't use cadavers for a number of reasons, and I as a student, I used cadavers. I thought they were valuable. I will say, when I was in the cadaver lab, I still remember, though, probably 80% of my time at the cadaver was picking out fat,
Right.
So I'm not sure all of that time that I spent in the lab was necessarily value added from a learning perspective. But nonetheless, all else being equal, certainly being able to touch and feel a human cadaver, all else being equal, human cadavers is probably a great way to go. The problem is not everything is equal, and cadavers are increasingly expensive. There's incredible regulatory environment around the use of cadavers. So if you happen to be in a medical center setting, for example, where there's cadavers that are being repurposed for a lot of other health professions programs, a medical school, PA, nursing, and all that, then maybe the cadaver utilization is justified and helpful. But the reality is, in a lot of programs where that infrastructure doesn't necessarily exist, it just doesn't make sense to set up a cadaver lab for one or two health professions programs, especially in light of the fact that the data would suggest that a lot of these synthetic models, the digital applications that we have now for anatomy, are frankly, the outcomes are equivalent to the use of cadaver in terms of anatomical knowledge and recall and those sorts of things. So ultimately, I think everyone sort of has their preferences, and if you ask the more senior kind of anatomists that are out there, they live and swear by, cadavers, and, they can't imagine a world that doesn't utilize cadavers. But if you talk to the younger generation, they're very, very comfortable with these synthetic models, pro-sections, digital applications. And frankly, some of these synthetic models now that are being developed really rival human cadavers very closely in terms of their functionality and feel and texture and those sorts of things. So it becomes harder and harder to justify human cadavers. And if I were to put my sort of, crystal ball forward, my guess is, 10, 20 years from now, cadavers are going to be, for the most part, not necessary because our synthetic models are going to be so useful. So in our curriculum that we've developed, we're using synthetic models, pro sections, as well as digital applications, and it's really the combination of that we feel like gives our students a very robust experience with anatomy, and that seems to be playing out so far in terms of its carryover into the other parts of the curriculum.
Got it. And then your proposed model seems to place a large degree of responsibility on the student for learning, right? Because you're not necessarily always spoon-feeding information. And I've heard you in other podcasts and lectures talk about the differences between child education and adult education. And even in a lot of medical graduate programs, they still kind of utilize that child education model where, you sit in class for 8 hours a day and you take notes and people tell you this is what you need to study for the test, whereas your model, again, kind of preaches autonomy to a much greater degree. So can you speak to the difference again between child education and adult education and how, what your sort of priority has been in your particular educational model?
Yeah, no, that's a great question, and this really can ruffle a lot of folks' feathers when you talk about this. But pedagogy, that word itself stems from ped, the child sort of learning, and certainly our educational model is largely built on this idea that students sit in a classroom and listen to the expert in the front of the room communicate through a one-way pipe and teach them what they don't know. As if that pipe goes one sort of direction. And so it puts a lot of onus on the faculty to be this sort of universal source of knowledge, and the students listen with open ears and a blank slate, and otherwise the faculty have no ability whatsoever to learn. Now, that's obviously an exaggeration of sorts, but that's sort of you might call the typical child-centered, if you will, model, as opposed to andragogy, which is, again, more of an adult learning sort of a model. And that's really what our curriculum is sort of built on, is where we put a lot of the onus and the responsibility on the student to actively learn. And so, the other part of it is again, PowerPoint perhaps was the worst invention to mankind, at least for academics, because it chained faculty behind a lectern and a computer, and it sort of redefined the role of faculty to giving a good lecture. And we just don't think that's a good use of students or faculty's time. And so you've got 250 PT programs, you've got 250 different introduction to biomechanics lectures. Why can't we enlist the world-class subject matter expert to record the very best introduction to biomechanics lecture and then share that across programs, and the students can watch that on their own devices, on their own time. They can do the readings, they can be prepared, and when they show up in class, they can now engage with the faculty in a much more collaborative discussion involving clinical reasoning. And so again, just a higher order learning process that takes place between the faculty and the students. So going through our program, certainly takes an additional level of sort of responsibility, if you will, but we find that our students are really rising to the occasion and really thriving in the model because of the flexibility that they're afforded, and to some extent the trust that's placed in them to take responsibility for their learning.
Yeah, and what's really interesting about that, from an admissions standpoint, how are you able to vet candidates and determine if they're going to be a good fit for your model? Because even if you look at someone's college transcripts, for example, they might not have taken classes in the same sort of system that they're going to be taking classes when they attend your program. So there's not really a precedent for what you're doing necessarily. So, what kind of metrics do you use to determine if someone is going to be a good fit for that model that places much more of a premium on independent learning?
Yeah, it's a great question, and we approach it from a number of different angles. We have what we call an assessment for readiness for blended learning that our students complete that sort of gets at their proficiencies with blended learning technologies. We do a virtual interview rather than a live interview. We use a platform called UCU, in which the student shows up online at a designated time for their interview, and a talking head program director asks a series of 4 to 5 questions. The student, it's a high stakes sort of interview in the sense that the student listens to the question, they have a few seconds to gather their thoughts, and then they record their response in a sort of live format. In other words, they can't re-record it. It's a one chance. It's like you're in a live interview. And so that tends to get their familiarity with, again, they can use a webcam, they know how to dress appropriately in a virtual sort of setting for an interview. And so there's a number of those kinds of steps. We assess a lot of things like emotional intelligence, grit, caring and empathy, a lot of the so-called soft skills as well, that all go into the decision-making process to try to identify that ideal candidate. Now, I will say one of the things we've really learned is that, when we initially started down this process, I fully thought that the student we would have would be this so-called adult learner that would look a lot different, perhaps, than a student that might go to a so-called traditional program. What we're finding is that, yes, there is some distinction, but it's not nearly the distinction we thought it might be, primarily because what we're learning is that especially these younger students, they have grown up with blended learning throughout their time in elementary, junior high, high school, and are already well-versed in blended learning technologies. So we're actually starting to think that the kinds of students that are applying to our program are becoming more and more the traditional student as opposed to someone different. In other words, what we're sort of seeing is that perhaps these traditional brick and mortar programs are going to soon find themselves facing an applicant pool who doesn't recognize the way that education is happening in those models, because the students are, blended learning is being adopted now throughout the educational system. And so we think our student is actually becoming more and more traditional over time.
That's interesting. So essentially you're saying that the generational shift has already begun. And I think that kind of segues nicely into some of the changes that are occurring in healthcare. And we've been speaking mainly in the abstract here, but there are obviously certain political realities that you're going to have to deal with in proposing a shorter curriculum. And just some context for the audience, for people who aren't physical therapists. So physical therapy is trying to be a more autonomous profession where, a patient can see a physical therapist through direct access, which means it doesn't require a referral from a physician. So again, trying to increase professional autonomy. And there are certain professions that obviously don't want that to happen for financial reasons. And it works both ways, because physical therapists are equally guilty of trying to prevent other professions from gaining more autonomy, like athletic trainers and personal trainers and massage therapists. So everyone kind of acts on their own self-interest. And there's a lot of fear-mongering that goes on. And obviously, it's very difficult to truly assess for competence. And one of the ways, from a political standpoint, that professions do it is they'll equate duration of your formal education with competence. So part of the reason why I think physical therapists transition to that 3-year model is because they could say, now we have 3 years, which is a little bit closer to what a physician or an osteopath or a chiropractor might have in their education. And you're proposing that you cut the program by a year. So the inevitable reaction from, if this model sticks, from other professions is going to be, now they only have 2 years of education. How are they going to be able to identify when somebody has a medical red flag, when their back pain is a result of cancer and not because of something, soft tissue related? So how do you address those political realities? Because that they're coming, and again, they're not necessarily, duration of education isn't the best measure of competence, but in a world of oversimplification, people are going to really hang on that.
Yeah, and I would answer that question, I guess, in a number of different ways. First of all, educational creep, if you will, is a phenomenon that's happening across the educational spectrum, and particularly in health professions. And when I say educational creep, what I mean by that is higher education has seen its best days, where clearly students are demanding education, and higher ed has been more than happy to make programs as long as is absolutely possible. So this trend towards shorter duration kinds of programs is, I think, a macro trend that we'll continue to see, not just in PT, but you're starting to see it in law schools, going from 3 years to 2 years. You see this now in some medical schools going from 4 years to 3 years. And so I think this is trend, if you will, is not one that's just going to be limited to PT in such a way that leaves us kind of isolated as now having less education, so to speak, rather than more. The other part of it is when we went to the 2-year model, first of all, CAPTE, the accrediting body for physical therapy education, has very, very robust requirements around the number of credit hours that are necessary to be accredited. So although our program is shorter in calendar months, so to speak, to make sure this is very clear for anyone who is listening, we don't apologize at all for the breadth and depth of the content that is included in that 2-year period. So in our program, for example, we've probably got 120-ish or so credit hours, but it's delivered in an accelerated format. So to get from 3 years to 2 years, one of the main things that we did is essentially eliminate the white space from traditional programs. You know, there's no long summer breaks. There's no 3 to 4 weeks off for Christmas. Our students are in class over a 2-year period for 96 weeks. That's 48 weeks a year. So there's only 4 weeks off. A week for Thanksgiving, a week for Christmas, and a week, or so in between a couple of the semesters. So it is an accelerated model. The students are engaged. I think of it as a working man or woman's kind of program. I mean, they're highly, highly engaged the entire period of time. We're seeing our students spending probably 55 to 60 contact hours a week. So although the calendar months are perhaps shorter, they're still getting very much the same. Nothing is cut out of the curriculum in terms of what they need to graduate, become licensed, and be proficient. And then finally, the way I would respond to that is we still look at our model as a 3-year model. It's just that in year 3, we're really encouraging our students to graduate, become licensed, and then go on to post-professional residency training. And so we fundamentally believe that more and more clinical education needs to occur in the post-licensure residency environment. And we're seeing that play out now as our first class gets ready to graduate from South College. About 70% of our graduates have been matched to residency programs and will continue their formal education, if you will, through the end of 3 years. It's just that over that 3-year period, they'll have their DPT, become licensed, and then also complete a credentialed residency program and become board certified. So we think in many respects, our students over that period of time are going to get a better, higher quality education compared to a student that just goes to a 3-year DPT.
Yeah, you make some great points, and I think the overriding theme is that every profession and field should be looking to streamline their educational pipelines and kind of trim some of the fluff. And regardless of the politics involved, I think that, again, the monopoly that the traditional model in the university has on education probably isn't sustainable for a lot of the reasons that you mentioned previously here. Now, one thing that I don't think is debatable is the importance and the value of clinical education. I've heard you talk a lot about how that you place the highest premium in your program on quality clinical education, and I've also heard you say, and this has been my experience as well, that pretty much anybody with a pulse can be a clinical instructor. So how are you guys in your program vetting clinical instructors to ensure that the students in your program are really getting the most out of the most important time of their clinical education, which is their rotations and their internships?
It's a great question, and again, we could spend an entire podcast on clinical education. When we shifted to the DPT, academic programs put a lot of effort in upgrading their didactic curriculum, again, pharmacology, radiology, imaging, but clinical education has not been touched in over 50 years. We largely send students out to disparate clinical sites that may have very little relationship with the academic program. And we sort of hope and pray that our students learn something while they're out there. And that may be a bit overspoken. It always offends sort of clinical educators when I say that. But that really is kind of what we do. The students don't have a curriculum. They just sort of learn by osmosis based on the patient that randomly shows up at the door. And if their CI is a really competent, capable, highly engaged CI, the student can have a really good experience. But even with the best CI, it's like the entire responsibility of that educational experience falls on one individual. And that's a lot of pressure to place even on the best CI. So we've had the luxury on the EIM side over the last 10 years of training a lot of residents and fellows, and there are now hundreds of these residents and fellows that all sort of have been through a more standardized blended learning sort of curriculum, board certified, in some cases fellows. And that network of clinical sites is a real asset for us because we can leverage that now into our entry-level internship experiences so that our students are being placed in a network of clinics that have some consistency in their training and in their experience. And then when our students go out on their internships, rather than just sort of throwing them to even a real quality CI, our students are still engaged in a now clinical education curriculum. So each week they're going through a consistent number of modules and learning activities. They're staying connected to their classmates online. One of the problems of current clinical education models is that when our students go out to the clinic, they're mostly disconnected from their classmates as well as their academic institution, other than through this very loose tether that they might have with their director of clinical education, that calls once or twice while the student's out on rotation. But for the most part, the student is pretty disconnected from their program. And so we want clinical education to look and feel as robust and consistent as it does when they're in the didactic phase of their curriculum. And so while our students are out on clinical education, they're still engaged in coursework just like they are in their didactic phase. It's just more clinically education-focused curriculum.
Got it. So it just seems like you've essentially standardized your clinical education program much more than the typical institution where they just, you go off and I'll see you in 12 weeks and whatever you learn. Now, you continually keep bringing up imaging. I know that's a big thing in our field because it's the idea is somehow that if you have some idea of how to interpret MRIs and X-rays, that it increases your ability to be sort of a primary care type medical provider. But is that even really the right question? Because you and I both know that the way these imaging courses work in entry-level programs is you do like maybe a 2 or 3 day crash course, and when you're immersed in that environment, yes, at the end of those 3 days, you're somewhat decent at being able to interpret those images. But then if you don't look at it for a couple months or a year, it doesn't really matter. So shouldn't the idea be more, how can we identify patterns in our subjective exam and our clinical exam so we know when to refer out to a specialist versus making us really good at reading these images? Because even a primary care physician probably isn't that great at, being able to look at an MRI of someone's lumbar spine and determine if it's a discal injury versus a stenosis. But the more important thing is to be able to recognize, wow, there's something going on here that I'm going to refer out for imaging and then have the specialist actually interpret the image, somebody who does that every single day. So again, are we really asking the right question with this, trying to do these sort of cursory imaging courses versus emphasizing more of the pattern recognition and being able to recognize when somebody needs to be a specialist versus trying to be specialist ourselves? Does that kind of make sense?
No, I think your point is well taken. When it comes to decisions about imaging, I think you're exactly right. I think the decision of when to refer and to whom to refer is far far more important than some technical ability to read an image. I mean, we all know in most cases for liability purposes alone, you've got to have radiologists now, reading most images, regardless. I mean, and you see this even in, specialist offices like orthopedists and others that will routinely get second opinions for reading, films and MRs and those sorts of things. So, yeah, the technical skill of reading films and images is interesting. It's useful, and some amount of perhaps training around that's helpful. But understanding screening for, that exception, if you will, rather than the rule, and knowing when to refer is far more important. The other thing I would say is imaging, at least when it comes to musculoskeletal problems, much like pharmacology, surgery, the opioid crisis, sort of falls, I would say in one of those, high cost center, high risk kinds of categories that we need to see a lot less of and not more. We certainly know that imaging in the spine, prescribing opioids and doing back surgeries has been a disaster in healthcare. And so, I was a physical therapist in the military for 20 years. And of course, in the military, we have these advanced so-called practice privileges, right, where we can order images, MRs, and plain films, and we can order non-steroidal medications and those sorts of things. And gosh, in the history of my career, I probably ordered a dozen plain films and, a few MRIs here and there. But it wasn't an everyday part of my experience at all, by and large, because so many of our patients need less imaging, not more. And so, when it comes to imaging, I couldn't agree with you more. It's really about clinical decision making and knowing when, and I would also argue when not to refer, as much as, again, the technical ability to read the results.
Yeah, that's a great point. And then you just brought up your military background. How has your military background influenced your teaching methodology? Because, I'm from the Air Force as well, and I did a medically intensive job in the Air Force. And I mean, we learned how to do, I had a much higher scope of practice in the Air Force than I did as a physical therapist. And we learned how to do things like surgical airways and chest tubes in less time than it takes to finish a DPT. So again, I was kind of taken aback when I went to the civilian educational program, because I thought, wow, they're taking way too much time to teach some of these very basic skills. I think there are other ways to kind of to solidify those things. So has your military background altered your perspective on education in any way?
Yeah, in all the past, couple of years of doing interviews like this, I think that's a question, I haven't been asked, and yet it's probably one of the most important questions to ask in terms of where does this model actually come from. And so the short answer to your question is yes, it's been absolutely influential, because I'll use the Army-Baylor PT program for example. It is still one of the shortest programs in the country, primarily because the students that are in the Army-Baylor program are being paid for by the federal government. So their motivation is to get them, out of school, as quickly as possible. They're in the classroom. It's a more traditional program in the sense that the students are in class all day, but they're in class from sunup to sundown, 5 days a week. There are very few breaks. These students are employed, so their full-time job all the time is going to school. And so the 2-year DPT model very much stems from what I would, it looks very similar to the Army-Baylor model in the way that it's full-time and more than full-time. It's just done now in a blended model as opposed to a traditional kind of brick and mortar setting. And, the other real similarity I would probably say is in the way that our labs are conducted. The military has, in PT, has a number of intensive courses each year that might be 1 to 2 weeks in length, where physical therapists from around the world get together for advanced sort of practice skills and those kinds of things. And again, the military is funding these therapists to come from all over the world. It's very expensive. So by golly, while they're there for a week or two, we're going to use that time very well. And we're going to start at 7 in the morning and we're going to run through 7 o'clock at night. And it's work hard, play hard for 2 weeks, and you go home completely exhausted. That's very much the model that our lab immersions are sort of based off of, where our students are engaged in highly organized. Every 5 minutes, we're moving on to a new learning activity. I mean, these labs, when you see them in action, it's not a bunch of just random teaching that's going on with a lot of side discussions happening on the side and those sorts of things. They are prescripted in sort of what I would call military style, if you will, because they're very, very organized, and the students get lots of repetition and practice, so that when they leave that lab immersion experience, they have made significant improvements in terms of their hands-on skill, just because they've been so immersed in those skills over that 10 to 12 day period.
Yeah, and I mean, just from having come from a similar background as you, I could hear the military person in you in every answer that you've given, which is why I asked the question. Now, next topic I want to get into, and this is something that I think is germane to any profession, whether it's legal, physicians, is kind of the disconnect between actually preparing a competent provider or practitioner versus preparing for a licensure exam. Now, you and I both know that in the physical therapy world, the licensure exam and the questions they ask cannot keep pace with current evidence in the field and best practice. So a lot of times what ends up happening is students spend a lot of time memorizing things that they know aren't actually applicable to the clinical world, but the answer is always, well, you need to learn it because it's on the test. And I've always thought, why not teach people what's going to make them a good provider, and then they can cram all the information they need for the test in the month or two before the exam. I mean, people are pretty good at taking tests by the time they get to a doctoral program. So how do you strike that balance? Because obviously, even you're trying to get your program off the ground. If people don't pass the boards, if they have a low success rate on the first try, that's not going to be good despite everything that you've talked about, all these theoretical things that may seem superior. So you have to kind of appease that crowd. So how do you strike that balance? I know it's a pretty difficult one.
Yeah, no, it's a fair question, and ultimately you have to balance a bit of both. I mean, I can assure you that when we were designing this curriculum, I don't know that we ever asked ourselves, what our students need to know for the licensure exam. So I can assure you that wasn't our focus, because I do agree with you that a lot of those sort of factoid kinds of things, are covered in all of the various test prep sort of applications that are out there. And that we really wanted to spend our energies building a next generation sort of therapist. We're happy to let the licensure exam sort of catch up with us over time. So, for example, in our curriculum, we really emphasize a lot of the so-called, I hate to use the word soft skills because they're anything but soft or unimportant, but like caring and empathy and mindfulness and compassion and the ability to communicate with your patient, motivational interviewing, therapeutic alliance, all of which, are critical to the outcome of the patient. And I bet that there's very little, if any, emphasis of those skills in the licensure exam. So, I think you have to bridge the both. CAPTE at some level drives a lot of what you have to include in the curriculum, and so you certainly have to meet that standard. And that standard is a standard that sort of fits with what the student needs to know for the licensure exam. I will say in some cases when it comes to the CAPTE criteria, especially when you get to the sort of the what you need for the licensure exam content, we try to barely deliver that bar. In other words, those are criteria that we have no interest in exceeding or shining on. We simply want to do the bare minimum to meet the criteria, and in all fairness, to prepare our student for the licensure exam, but we're not going to overemphasize those sorts of things by any means.
Yeah, and then on the licensure exam with PT, it's a little bit off topic, but since you're a leader in the field and I have you here, I wanted to ask this, and it's kind of more of a philosophical question. So just for some context for the people who aren't familiar with the physical therapy licensure exam, essentially, regardless of the state that a student plans on practicing in or the state that a student attends school, that student can take the licensure exam prior to graduation, provided that the program director signs a letter saying that the student is in, quote, good standing, unquote, which you would think by the time someone's in his or her third year of a doctoral program and on the last clinical affiliation, that would be more rhetorical and a formality. But so essentially, without getting into too much of the specifics, program directors have ultimate veto power in whether or not a student is allowed to take the licensure exam early. And there have been some people who have actually quantified the opportunity cost lost when students take the exam after graduation as opposed to before. And obviously, if you've passed your licensure exam prior to graduation, it makes you more marketable from an employment standpoint. I know that your program obviously places a huge premium on autonomy and responsibility. And a lot of times, the answer from program directors, a lot of them will just flat out say, no, I don't want the student to take the test early. And the reason they give is typically, well, sort of like, we know what's best for you and just listen to us. You'll end up doing better. And there's no necessarily data to back it up, but it's kind of more of a patronizing answer than anything else. So what are your thoughts on that? Because I think it's actually really fundamental to the autonomy in the profession that we answer this question correctly.
Yeah, it's a very, very fair question. And obviously the implications of taking it early or not somewhat depends on the state. In states like Texas, where you've got provisional or temporary licensure, the need to take the test early probably doesn't have as much of an impact because you can get temporary licensure sort of in lieu of passing the exam. In states, though, that don't allow for temporary licensure, there is no doubt that if you can take and pass the exam early and immediately come out of school with a license and start working on day one, that's a valuable sort of asset to have. And I think your point is very well taken on sort of this kind of paternalistic or maternalistic kind of we know best as your educators what is good for you. That doesn't surprise me at all. That's very, very common, right, in kind of our educational models. And I think ultimately the data will prove it out. I think the good news is that there are a number of program directors that are allowing their students to sit for the exam early. And I think over the next year or two, I think the data will start to win out when we see, my guess is, and again, I'm not looking at the data, but my gestalt says that we're going to see similar pass rates when exams are taken early versus when they're taken later. I can say, we have gotten asked this question in our 2-year model. Right now, we're not entertaining our students taking the exam early because the 2 years is already so accelerated. Having said that, I wouldn't take it off the map that we might well have students taking the exam potentially 18 or 21 months or so into the program. Part of what makes me hesitate is because, again, some of these courses like pharmacology, imaging, and others that are taken in the traditional didactic phase of the curriculum, for some of the reasons we talked about earlier, we think courses like imaging and pharmacology actually belong in clinical education. And so in some cases, we have those courses being taught in the most terminal phase of clinical education, as opposed to in a traditional sort of 3-year model. The didactics have been delivered in the first 2 years, and then clinical education is so-called just clinical education. And in our case, it's clinical education plus didactic content that's sequenced throughout that clinical education. And so, are our students at risk for not passing the licensure because they're truly still going through didactic curriculum up until the very end of that 2-year period of time? And again, I think the data will bear this out over time. I don't really have good answers for that, but nonetheless, we feel pretty comfortable that students still feel significant value, even if they're taking it after they graduate because they've only been in school for 2 years.
Yeah, and I mean, not that we have to belabor this, but another question is almost, should it even matter what the data says? In other words, let's say the data says that, yes, students who do take the boards early are more likely to fail the exam on the first try. Should that data trump sort of the student's choice as the paying customer? I don't know. What do you think about that?
Yeah, I mean, at some level, academic programs are right, wrong, or indifferent, judged by their pass rates on the exam. So, if as educators we're sort of wittingly, knowingly putting our students in an environment that puts them at risk for failing the exam, at some level, I don't know that that's in the best interest of the student. But I hear your point from the perspective that all else being equal, let's put the power in the hands of the students and let the chips sort of fall where they may. And I think in the case of the 3-year program, I would not have any concern as a program director in signing off early on one of my students taking the exam. And frankly, if I've got a student in now the 3rd year of the curriculum that I'm worried about failing the exam, I'm kicking myself wishing that I would have identified that in the first semester and helped get them out of the program, early. And that, by the way, is one of the other little hallmarks of our program. Our first semester of coursework is loaded up. It is intense, and it is designed as a weed-out semester because we really don't want to have students, spending 2 years in school, paying premium tuition, and then getting out there and never being able to become a licensed therapist. And so we do a disservice to the student when we sort of string them along and continue to offer them remediation after remediation, because it's those students that invariably are at risk for not passing the exam. And it's not just a matter of it reflecting poorly on the academic program. It's a big disservice to the student ultimately. And so one of the biggest favors we do to students, although it's really hard, is disenrolling students early on. And that's a very, very hard thing to do, but it is ultimately one of the most humane and kind things that you can do, is to help a student find their way into another profession sooner rather than later.
Yeah, I think that's actually a very satisfying answer. And I asked the question, because your program is unique, I asked the question in the context of the 3-year program, but I think that what you said absolutely is relevant to both models. Now, I know that you're very active on the internet and social media, so how can people learn more about your programs and what you're up to?
Yeah, no, it's a great question. You can always reach out to me on my email, John, John, at EIMPT.com. On social media, you can find me at Childs JD, Childs JD, and that's whether it's Facebook, Twitter, Skype. They're all kind of out there. And, happy to entertain, answer questions. The 2 PT programs we're working with now, South College, we're into our 3rd year with them. They've been just a fantastic partner with us, and now we're working very closely with Baylor University in Dallas. So, a lot of exciting things to come, and we're certainly always willing to listen to criticism as well as those who want to encourage us. We've learned a lot from our biggest critics. One of the things you learn very quickly, if you're going to start something that's new and perhaps different, you're invariably going to hear from some folks who don't just disagree a bit, but disagree a ton, and are not afraid to tell you about it. And although that criticism can sting at times, you invariably learn a few things. And if you're willing to listen, you can actually really improve. And so we've learned a ton over the last couple of years from some of our harshest critics. And so we really try to actually welcome and embrace the criticism along the way as well.
Well, I mean, certainly every profession needs people who are willing to ask difficult questions and take risks like you are. So thanks again for your time, and thanks for what you're doing for the physical therapy profession.
Thanks for having me, Doug. It's been fun.